All right, hi guys. Welcome to the first of 3 lectures for the HEMONC section. This is going to be the shortest one. We're just going to focus very quickly on some anemia um, topics and hemopoietic agents. It's not going to be too intense, so bear with me. Anemia intro, just to talk about some brief things about what anemia is. You have a deficiency in red blood cells, and the problem with this is that your oxygen can't get to your cells, and that's a problem, of course. So we want to get that up if we can, but there's different ways we can do that. And I just put some normal lab values in here in case you're curious about like hemoglobin versus hematocrit. Usually hemoglobin is the common lab that we're talking about. I don't think many people use hematocrit anymore. I think it used to be kind of a popular one, but hemoglobin is much more commonly used. And really does depend on your baseline. Some people can run a little anemic. It's not necessarily anything to be concerned about. Men tend to be a little bit higher than women, and older people tend to be a little lower than younger people. So if you have an older person that is just on the verge of anemia, maybe they're an older man and is, I don't know, his hemoglobin's 11 or 12 or something like that. It's probably nothing to be too concerned about. On the other hand, if his baseline is 16, that's maybe a pretty big jump. So maybe there's some blood loss there. A sudden drop in hemoglobin is a sign of some sort of frank blood loss. So that is something we look at, if we're thinking about a GI bleed or something like that, where there's a problem with actual volume loss. To approach anemia treatment, there's a couple things we can look at. The first things we're going to talk about are pretty straightforward, and they're really just supplements. So bone marrow hematopoiesis requires a couple of cofactors. Iron, folic acid, and vitamin B12 are the major ones. And there's also some growth factors. We're going to talk about all of these. The causes of anemia, there's a lot of different things to consider, and you'd of course want to consider your patients and what the root cause of. Oops, sorry about that. Apparently this recording software uses a lot of memory. But what we want to talk about is just the way we can approach anemia treatment. We're going to go over anemia a little bit more during kidney disease, specifically because it's a very common thing that's comorbid with chronic kidney disease patients. So we'll get into this in a little bit more detail in the context of an actual disease, as opposed to just saying, well, this is anemia, let's treat it. But basically, if you have some sort of correctable cause, if you lost blood, if you're malnourished, those are things we can correct in different ways. But there's some diseases like chronic kidney disease, for example, that you can't necessarily cure chronic kidney disease in most cases. So you're probably going to be looking at managing this as a chronic condition alongside that other chronic condition. Some implications of anemia, again, decreased oxygen delivery to tissues. You guys probably know what happens when that occurs. And then increased mortality. Again, chronic kidney disease patients, higher mortality risk with ongoing anemia that's not managed. Chemotherapy patients undergoing various cancer treatments or with various malignancies are going to have a higher rate of mortality. And heart failure, elderly, general hospitalized patients also. So it isn't something we want to totally ignore, but it's not. It is something we want to treat, but then again, there are a lot of factors that go into it. And again, you have to look at your patient and figure out what's their baseline. Is this worth being aggressive about? And how do we treat this specifically? Because it can get a little tricky. All right, so there's a couple things we look at when we're deciding how to start initial therapy. And MCV is the mean corpuscular volume. It represents an average volume of a red blood cell. And depending on whether the patient's macrocytic, which is a larger than normal red blood cell, or microcytic, smaller, might be able to decide where you start. And that's really looking at the basic therapies here. So our basic therapies are basic dietary supplementation. So folic acid, vitamin B12, and iron. If somebody is showing macrocytic morphology, folic acid and vitamin B12 may be a deficiency causing the anemia. If somebody's showing microcytic morphology, iron deficiency may be the cause. So then you might pursue one or the other that way. And that's a pretty easy lab test we can do to give us a little bit of a clue as to how we treat anemia, as opposed to just treating somebody without really knowing what you're doing by supplementing everything all at once. With iron deficiency anemia, you have a couple different labs you can measure, and honestly, there's a few different ways you can approach this. And serum iron might be the one you think is obvious, but it actually isn't the best way to measure iron. it's not really easy to interpret, and there's a big variation between morning and evening with patients. So it's hard to get a really consistent read on what exactly serum iron is telling you as far as a diagnostic tool. Total iron binding capacity, or TIBC, is serum transfer and iron binding capacity, and it represents the availability of iron. It does not fluctuate, and it's elevated in iron deficiency anemia. It may change in various disease states, so that can be a clue. If somebody has a different disease, it might fluctuate that way, and give you a clue as if it's comorbidity due to the disease or just something new that's happening altogether. Ratio of serum iron to the total iron binding capacity is called transferrin saturation, and this is a ratio we can test. So while serum iron on its low and difficult to interpret, if you look at the ratio between that and the total iron binding capacity, you get maybe a bit more of a useful value, and it's generally low. That ratio would be low in iron deficiency anemia, and that might give you another hint as to whether this patient needs iron supplementation or not. And finally, you have serum ferritin, which is the measure of the body's iron stores. It's probably the best indicator of low iron or iron overload in the case it's high. And the decrease is really only associated with IDA. So if you're looking at the best lab here, that's probably it, is serum ferritin. So how do we treat iron deficiency anemia? Well, obviously we want to supplement iron. There's a lot of different products on the market. Most of them come over the counter. There's tablets and liquids available, and I'm going to talk about some of these in a minute. There's dietary recommendations too for people to take a certain amount of iron. Iron-rich foods can be a little bit difficult to get a lot of. Some people may just not have that as part of their normal diet. So whenever you're looking at approaching something as a treatment and changing somebody's diet because of it, I always get a little hesitant because I don't know if people. It's one thing to prescribe a medication and have somebody take it. It's another thing to have somebody change their diet in the hopes that it helps. Some people may be very open to that, so that could be a good way to go, but other people may be very resistant to changing their diet. GI absorption of iron products is quite challenging, and there are a couple recommendations. Usually you want a really acidic environment. The stomach's quite acidic, but you want that acidity to carry into the lower intestines a little bit. So we want orange juice or other acidic vitamin C rich foods. You'll see iron sometimes combined with ascorbic acid, which is just the medical term for vitamin C. And then also with meat, for some reason meat tends to have like red meat will help iron absorb. Why, I don't know. I mean, red meat contains iron on its own too. Maybe that has something to do with it. Milk and tea contain chemicals that can either create a more alkaline environment, which doesn't help absorption, B, can chelate iron, which doesn't help either. My philosophy with iron therapy, some is better than none. People generally find it hard to tolerate. It can have some GI side effects. It's not necessarily the best drug as far as a patient satisfaction goes, because it can really cause some stomach upset, nausea in some patients. So when you're telling them to take their iron that's already causing them upset stomach with maybe something really acidic that could possibly cause some sort of a heartburn type scenario or cause some reflux, it's not going to end up being the greatest solution for the patient. So if they can take some iron, I think it's better than none. Some of it's going to absorb. Overall, it's poor absorption even in the best case scenario. So try and get what you can into the patient however you can. So besides some of the nausea and vomiting, you can end up with diarrhea or constipation with iron. It can happen both ways. And people's feces tend to be quite dark. So it's a good counseling point if you're prescribing iron to somebody to let them know that they should notice this so they don't freak out and think that they're bleeding into their stool. Acid suppressing agents impair absorption. That should make sense based on what we just talked about. It needs an acidic environment to absorb. So if you have somebody who's on a chronic regimen of acid suppression, like a proton pump inhibitor, which would be like our drugs like Prilosec and Nexium, the common over-the-counter anti-heartburn drugs like Zantac and Pepcid, which we'll talk about next semester in detail, those all would be problematic with an iron regimen. Well, if you could, you'd probably want to hold them while the person's on iron and then see if they can get up. Ultimately, again, if you have to give them together, you're probably going to get some absorption, and some is better than none, but it's not ideal for sure. I put these pictures up here because this is what over-the-counter iron tablets look like. Look quite a bit like candy, like M&Ms, I think. So it's something to remember that iron can be pretty toxic if you take a ton of it. And so if a kid found these and ended up eating a whole bunch of them, you could end up with some problems potentially. So it's just something to keep in the back of your head. Nothing other than a fun fact mostly. IV iron is something that is available. So if somebody is having issues, maybe you're sure it's iron deficiency anemia, you've tried oral supplementation, it's just not working, IV products are available. They're useful in a variety of settings. And also if you think about malabsorption or malnourished patients, like we're going to get into the chemotherapy lectures here in a second. So with that in mind, if you think about somebody who's malnourished because they're on some sort of chemotherapy regimen or their cancer, their malignancy is causing it too, this is an option we can do to supplement somebody's iron without having to give them oral therapy that may or may not work because their absorption's poor or their diet is just, or they don't have any appetite or they're so nauseous they can't keep things down. So there's a couple different products on the market. I put them here. I'm not concerned you know this. It's just a reference. There's a few different ones, we like to use. And it really depends on provider specifics and what they want. I'd say iron sucrose is by far the most commonly used product, but there's a lot of other ones out there too. We'll talk a little bit more about IV iron with chronic kidney disease, so we'll get back to it. Okay. B12 is another replacement supplement we can give to help with correcting different types of anemias, and this one can be probably better influenced with a dietary change than like, for example, iron can be. Foods that contain B12 are there, so dairy products, eggs, generally meats like red meat, pork, poultries all have decent amounts. Oysters have very high amounts. Not many people eat those, so kind of scratch that one off. But there's some foods that are pretty common in the American diet. So vitamin B12 is pretty ubiquitous. I think it'd be hard to really get deficient in it, but some people may be on the little bit of a low end, or maybe if you're a vegetarian or vegan specifically, you could see how you're wiping out all those animal products, and that could lead to a possible deficiency because of B12 deficiency. So we have some products. There's oral, nasal, and sublingual tablets available. By nasal, I mean nasal spray, and oral and sublingual tablets. You usually do 1,000 to 2,000 micrograms per day. And then IV or IM therapy you can also do. So sometimes we have people do IM shots at home, and they actually get a prescription and take home these little vials, and they do like a shot every week until their levels come back normal, and they might do every month afterwards. A lot of people will be on a chronic vitamin B12 injection once a month. An oral B12 supplementation just doesn't seem to be as effective as the IM, so it's pretty common to have people on IM. Adverse effects of supplementing, very minimal. And again, consider supplementation for vegetarians or vegans. People with gastric surgery too also generally just won't absorb many vitamins quite as well as somebody without. So if they have a bypass history, you might want to consider this as a supplementation effort to prevent a deficiency anemia from occurring. And again, there is a serum level for this, so you can check this, just like you can iron. All right, folic acid, very similar to vitamin B12. Folic acid is also vitamin B9. It's another B vitamin. It's found in a lot of things, breads, poultry, fish, fruit. It's all over the place. But we can supplement it easily too. There's over-the-counter supplements that are available. There's also prescription strength supplements, more commonly known for prenatal vitamins. But if somebody's severely deficient, we can actually give folic acid IV too. So there's lots of different ways we can do this. If you're going to supplement B12 for a deficiency or for an anemia, you're going to probably supplement folic acid. They're synergistic. They work together. Usually, again, you're looking at two different areas. You're looking at iron supplementation or B12 folic acid. You could potentially see people do both, but usually it's going to be one or the other. Okay, so moving on to growth factors. So growth factor is the fourth tier we're going to talk about. And what the growth factors are versions of glycoprotein hormones that regulate proliferation and differentiation of progenitor cells within the bone marrow. So progenitor cells proliferate into a variety of different types of cells, including red blood cells. These are also known as colony-stimulating factors. They're biologic agents, they're large proteins, and they're injectable only, and they're quite expensive. But they aren't dosed quite as frequently, and you get pretty instant results. So if you give somebody a growth factor that's going to increase their red blood cell production, you're going to see those results fairly quickly. Whereas if you give somebody iron, who knows when you're going to end up seeing any results from that. If it's oral iron, you really don't know if they're even absorbing it. So this is a much sure bet, but it does depend on the pathophysiology too. And again, it's expensive, so it's not going to be something you're going to want to be using on a regular basis if you can avoid it. However, patients who are like CKD patients will usually have, or dialysis patients will have a growth factor as part of their regimen. So the growth factors that affect our red blood cells are erythropoietin, and that's the endogenous one. And then we have epigen and procrit, which are the products that mimic this, or epoietin is the other name. They induce erythropoiesis. So again, they're stimulating these progenitor cells in the bone marrow, increasing red blood cell production. So you see this a lot in chemotherapy. You see it used in HIV, and again in hemodialysis patients. Your kidneys synthesize erythropoietin endogenously. And so if you lose your kidney function, you have to supplement this somehow, otherwise you aren't going to have any of this and you're going to get anemic. Also, if you have a patient who is maybe had some blood loss usually the situation probably comes up where they've had blood loss. Great example of this is a Jehovah's Witness who won't accept blood products. This is a synthetic, so they usually will accept this. And so if you have, like, let's say you had a Jehovah's Witness who came into your hospital with a major GI bleed, they took him to surgery, repaired the bleed, but the person is still very low hemoglobin, and you want to increase those red blood cell counts, you can give erythropoietin. We've seen this done before, and it does work actually reasonably well. You know, sometimes you can get to the point where you're critically ill and you really need a blood transfusion, but if you have a patient who it's against their religion to do that, you're kind of in a rock and a hard place. This is really your only option. You could get hypertension, thrombosis. If you think about increasing red blood cell production, if you overdo it, you can end up with a bit thicker of blood, if you want to think about it that way, having too many red blood cells circulating around. And that really is overdoing it. You would monitor a patient regularly to make sure you aren't going too far over. We're going to talk about that in a bit of detail again during our kidney disease lecture, so we're going to come back to this. Usually give it about 1 time per month, with the exception of dialysis patients. And there's another product called darbepoetin, which is just a longer lasting version of epigen, but it's a similar modified erythropoietin with some different amino acid chains on it to make it last longer in the body. And then finally, colony-stimulating factors. This is a relevant thing to talk about, especially in the chemotherapy section. So what's important about this is that these drugs stimulate neutrophil progenitor proliferation and differentiation. They're given sub-Q and IV just like our erythropoietin agents. However, they increase our white blood cells and neutrophils. So what we're going to get is a product. When we talk about this product, what we're talking about is people who get really severely neutropenic. Usually that's because of a number of reasons. It could be because they have some sort of malignancy that's causing that. Sometimes patients who have, for example, a bone marrow transplant will be wiped out pretty much completely of their natural body's defense, which includes white blood cells and neutrophils. And then when it comes down to replacing that, you have to give colony-stimulating factors to get that back up and running while that bone marrow is recovering. Same thing happens with some drugs we have really will obliterate somebody's natural defenses, their leukocytes and their neutrophils. So we need to replace those with colony-stimulating factors. And I kind of mentioned some of those down there. Adverse effects, not too many. You might get some local irritation, maybe bone, skeletal muscle pain. It's hard to say if that's from certain subsets of populations that use this drug or if it's actually from the drug itself. But there's 2 products, filgrastim or pegfilgrastim being the longer lasting one, are the most commonly used ones. And it's pretty common to have some sort of association with this with a chemotherapy regimen. So if you work in oncology, you're going to see these used quite a bit. But that's all I want to talk about with respect to these. Again, we're going to come back to some of this with our kidney disease lecture, but that's it for now.